and it needs discussion at the earliest opportunity.
That's great, thank you. Our next question is around asking, can cirrhosis be treated with something more than urso? Now, looking a bit more into the question, I'm thinking, is the patient thinking further down the road, if cirrhosis is within the liver, what would be the treatment options as well as potentially urso at that point?
Yeah, so exactly. When I saw the question, I wasn't quite certain whether the person meant additional treatment for the PBC itself, or was referring to treatments for the cirrhosis very specifically. So maybe if we answer both of those possibilities. In general, the aim of treatment with PBC is to prevent progression of scarring, so progression of fibrosis. And that applies at any stage of the liver disease, actually. Doesn't matter whether the person presents with very early disease. Your aim is to prevent the fibrosis from progressing beyond early stage disease, or even if the person presents with cirrhosis, even if they present with cirrhosis, you might still want to prevent that cirrhosis from getting worse so that you can prevent the liver from ultimately failing. First-line treatment at any stage of liver disease will be ursodeoxycholic acid. If the liver blood tests return to normal or near normal with the ursodeoxycholic acid, you can be reasonably confident that the disease activity is controlled and there won't be further progression of scarring. And again, that applies whether it's very early stage disease or very late stage disease. You can still be confident that it's not going to get worse beyond that point. So if this person is asking, do I need additional treatment because I have cirrhosis? It depends on what the blood tests are like. If the blood tests have returned to normal or near normal, actually the urso is doing a good job and additional treatments are probably not going to add much. On the other hand, if the liver blood tests are still abnormal, if they suggest that the PBC is still active, then second-line treatments might help to prevent that cirrhosis from ultimately progressing to liver failure. There is a little bit of an issue, though, in late-stage disease about whether second-line treatments are going to do more harm than good. So if the liver tests are still abnormal, then this particular person asking the question will need to discuss with their consultant about whether second-line treatments would be helpful or in fact would cause harm. For example, we wouldn't want to use obeticholic acid in someone who had cirrhosis with varices. That's getting a little bit too late in the game. And if you look at the licenses for elafibranor and seladelpar, it's suggested that those drugs shouldn't be used if a person has already got hepatic decompensation. So it depends on many, many different factors. If the person was thinking, okay, what about cirrhosis itself? Are there any treatments for cirrhosis itself? There are no antifibrotics, so there are no medications that we could give to reverse cirrhosis. But there are some medications which we often use to try and prevent complications from cirrhosis. So, for example, if someone has cirrhosis and varices, we might give them beta blockers, such as corvidolol, to prevent bleeding from varices. If someone has got ascites, fluid inside the abdomen because of their cirrhosis, we might give them some diuretics to try and clear that up. We might give antibiotics to prevent infection of that fluid. And if someone has got hepatic encephalopathy, confusion because of cirrhosis, we might give medications like lactulose or rifaximin to reduce the symptoms from the encephalopathy. So I'm not sure which part of the question the person was most interested in, but hopefully we've covered both.
No, that's perfect. Thank you. We have a patient who's waiting for confirmation of their PBC diagnosis, and it started after they contracted a really bad episode of norovirus last year. Prior to that, all their bloods had been fine. They're asking if it could be connected. Their GP and consultant don't think so, but they seem to think it's a bit of a coincidence and just wondered if there's potentially any link to that.
Yeah, there's no known link between norovirus and developing PBC, so it's not thought to be one of the causal factors. Therefore, I think I'd probably agree with the person's consultant and GP. That said, having an infection does stir up the immune system. So if you were brewing PBC and you were just on the verge of developing PBC, then having an infection, norovirus, flu, whatever, that might be enough to just tip the balance and cause the PBC to emerge. But it was probably brewing already, if you see what I mean.
Yes, thank you. Got a patient who was diagnosed with PBC 5 years ago, shortly after being diagnosed with Sjogren's syndrome. They immediately started taking urso, and their LFTs have been normal since, and they haven't experienced any PBC symptoms. Last ultrasound 5 years ago showed normal liver echo texture. They had an ultrasound earlier this week which showed a coarsened echo texture and mild nodularity. So their questions are, why are they seeing these texture changes with normal LFTs? Should they be looking to other forms of treatment? And would potentially an MRI be appropriate?
I think that the person's gastroenterologist has already referred for an MRI, actually. So on that very last question, I'm just going to say that if the person's consultant feels an MRI is appropriate, then I'm sure that is the case. So go for it. Now, the question on whether people with normal liver tests will have progression of fibrosis. Most people with PBC who have normal liver tests on treatment will not experience any progression of fibrosis, based on very large studies. Huge studies would suggest that if the blood tests are normal or near normal, then progression is unlikely to occur. But you can never say never in medicine. There'll always be somebody who doesn't obey the rules, so to speak. And that's important to recognize, because it means that people should have regular blood tests. They should have occasional scans, occasional fibroscans, for example, just to make sure that that everything is staying stable. And that applies to people with normal liver tests as well as the people who've got the abnormal liver tests. The occasional restaging of the liver disease is important. So the gastroenterologist in this case was spot on to repeat the scan after a period of time just to make sure. The other thing to say, though, is that there are many different factors which can influence disease progression. It's not just the disease activity. There could be some other factors involved. It might be, for example, that this person has a fatty liver. Fatty liver is extremely common. That can come from metabolic dysfunction, associated steatotic liver disease. It can come from alcohol. It might be that this person smokes. Smoking can increase the risk of disease progression, and so on. So, I mean, there's a whole bunch of other factors that should be considered. I think in this instance, what the gastroenterologist probably wants to do is to do further imaging to see whether the scarring of the liver has indeed progressed, because it might not have. The liver might just look a bit different on the ultrasound scan, but not be particularly scarred. And then if there has been progression of fibrosis, I guess the gastroenterologist will then want to try and work out why that has happened, and then treat the underlying cause. And if it turns out that the most likely explanation is indeed the PBC, even though the liver tests are normal, then the gastroenterologist might consider additional treatments. But I don't think you could jump to that conclusion. I think you would have to consider all the other possibilities as well.
That's great. Thank you. We have a patient who's in Spain. They have overlap, PBC and AIH, currently taking urso and acetylcholine, but the PBC is not fully regulated. The urso isn't working. And I think they're just reaching out for some support in terms of what else they could try. They're asking what alternatives potentially for overlap when urso's not working, taking into account that OCA can't be prescribed in Spain and the 2 new medications are not available as yet either.
I think, unfortunately, there's probably too many factors that need to be considered here for me to give a particularly specific answer. If somebody has overlap, then it might be that the PBC element of the overlap is inadequately controlled. And if that were the case, then the usual second-line treatments might be helpful. Those would be obeticholic acid. I appreciate that that's not available in Spain. Fibrates, which I think probably are available in Spain, but as in everywhere else in the world, would be used off license. And then ilafeprinor and seladelpar, which are new, and therefore it doesn't surprise me if those are not yet available. But those are all potential treatments if the PBC component of the overlap is not controlled. You would also have to think about, though, the autoimmune hepatitis component of the overlap. It might be that that's which is inadequately controlled. And there's a host of alternative approaches to treating that. The person could benefit from going back onto some steroid. They could benefit from switching, for example, from azathioprine to mycophenolate. It could be that they need to have something like tacrolimus added, and so on. So there's many options here. But I think it really depends on the reason that the blood tests have not really settled down, that the disease isn't controlled. And I guess we don't have quite enough information for us to steer this person in one direction or the other. So I think unfortunately, I think they're going to have to go back to their consultant and discuss this in a bit more detail.
Great, thank you. We have a patient who's dealing with insomnia from our PBC and asking if there's any supplements or sleep medications that she could take to help.
Yes, so again, sleep disturbance in PBC is not unusual, especially common in people who've got bad fatigue. And you can imagine that it can arise for a number of different reasons. Some people might have sleep disturbance because they've got bad pruritus. If that's the case, then the itching needs to be controlled. It might be that they've got sleep disturbance because they're very worried about their PBC. If so, then that depression and worry needs to be addressed. It might be because of the fatigue symptom complex, just being part and parcel of that dysregulation which represents the fatigue symptom complex. So the approach, I'm afraid, needs to be very personalized, and therefore I can't really offer anything specific to the person who has sent in this question. But basic tips, which apply to all of us, would be things like making sure that you keep a regular sleep pattern, going to bed at approximately the same time every day, waking up at approximately the same time every day, trying to relax your brain well in advance of falling asleep, making sure that the bedroom is dark, making sure it's quiet, making sure it's not too hot, not too cold, getting exercise. And of course, that's a big challenge for people with PBC, but that does nevertheless help with sleep. Avoiding caffeine, avoiding alcohol, avoiding eating too late in the evening, avoiding stimulation, brain stimulation from the TV, from the phone, for an hour or two before trying to fall asleep. Avoiding naps. Naps can interrupt the whole sleep cycle, and so on. So those are sort of general things that can help all of us. In terms of very specific things, though, I think this person would need to have a chat with his or her GP or consultant to try and work out why it is that this particular person has sleep disturbance, and then go from there.
If it's related to any of the other symptoms. Yeah, no, that's great. Thank you. We have a patient diagnosed 2007, aged 56, fairly stable blood test results until around 2010, and since January 2024 been placed under the care of a specialist liver nurse. It's virtual clinics that she's attending. She doesn't get to see her blood test results on the NHS app. She's received a letter confirming ALT last result was 17 ALP 89 and nothing else. Also, there is no mechanism for advising of symptom burden in advance of the virtual clinic or seeing the blood test results. Is that a common method for monitoring PBC? And I think the question is around being able to talk about her symptom burden, isn't it? If she's getting her blood test results through but not being able to actually chat about the symptom burden, but it's a regular virtual clinic. Is that quite normal now?
It is, and I'm going to just sort of, potentially be a bit controversial and say that that's actually a perfectly good way of monitoring PBC, provided that the PBC is stable. Stable will be interpreted in different ways, but if, for example, somebody's got early stage disease, they have good control of the PBC, as in this case, and they don't have a heavy symptom burden, then a reasonably light touch approach to the monitoring will probably be fine. It is still being monitored, and that's good. The second thing I'd say, of course, is that actually a specialist nurse who sees a lot of people with PBC will probably know more about PBC than a consultant who doesn't see very many people with PBC. So the issue isn't the nurse particularly.
No.
Therefore, it probably does, as you say, boil down to the inability there to discuss symptoms, and that's somebody who probably doesn't benefit from a light touch approach. If someone does have bad symptoms, then yes, they do need the opportunity to sit down and talk about those symptoms. So they wouldn't really fit into my definition of stable, if you see what I mean.
Yeah.
I'd have thought that the right thing to do for this particular individual is to actually get in touch with the team at Portsmouth and say, well, this isn't quite enough for me because of, and then go from there. But in very generally, I would say that actually monitoring by a nurse is fine. They often have huge amounts of experience, and they will report back to a consultant. And light touch monitoring is also fine, provided that the condition is very stable.
Mm-hmm. We also hear great things about specialist nurses who often have a little more time as well to spend with patients.
Yes,
and that works extremely well.
Yeah.
It is quite a common thing where if patients are feeling they're not getting the opportunity to discuss their symptoms, so that's a really good general answer as well. So for any patient who feels in that position as well, that they want a bit more time or want to speak to someone specifically about their symptoms.
Yeah, and I guess we can extend it even more actually. If you're worried about the monitoring, speak up. There's no need to just sort of accept it. Just say something. If it turns out that team just does not have the capacity to address the concerns, then in addition, it is also possible to ask for referral to a different centre. So there's just no need to sort of grin and bear it. Speak up if you're concerned.
Mm-hmm. Great, thank you. We've got someone seeking in guidance on vaccinations for hepatitis. Their liver doctor said their blood work does not show protection from Hep A or B and is advising they get vaccinated. Their question is whether this is standard care for PBC, to see if there's a specific vaccine that's recommended.
Yeah. So in the UK, different countries will have different policies, but certainly in the UK there's a task force which decides who should receive vaccines, and they produce something which is known as the Green Book. And the Green Book does actually suggest that hepatitis A and B vaccination should be offered to people with chronic liver disease. So I think this person's liver doctor is correct to offer it. There's no specific vaccine, though, that a person with PBC needs. The usual vaccine is absolutely fine. In hepatitis A, there's actually a range of vaccines, but all of them would be okay. And probably this person's GP just needs to use whatever vaccine they ordinarily use. In people who've got cirrhosis, we also generally recommend that they should have vaccination against flu and vaccination against the pneumococcus, which causes pneumococcal pneumonia. So there are a few vaccinations which are generally recommended for people who've got liver disease.
Just going back to our previous question there, Doctor, we've had someone mention that they've, on our live stream, that they've not been to the liver clinic for nearly 2 years, as any appointments they do have keep getting cancelled. So their question is, how can you speak up if your appointments are cancelled?
Well, you can email. It's generally possible to work out what somebody's email address is going to be. You can phone up the secretary. You can ask the GP to contact the hospital on your behalf. So there's usually a range of mechanisms. Most hospitals will also have something which is known as PALS, the Patient Advice and Liaison Service. We often think of PALS as just being for complaints, but actually they're there for advice and liaison. And they're a very good way of getting in touch with a clinical team if you're struggling to get in touch with the clinical team through any other mechanism.
So don't just accept that. If you still need to see someone, then make sure you're following that up and getting back in touch.
I think so. I mean, it's if your car was making a strange noise, you would get it sorted out. If your hair was too long, you'd go and get a haircut. If you had toothache, you'd go and see a dentist, right? I mean, the same applies actually, that people can and should take charge of their health. And repeated cancellations, well, that's something that shouldn't be tolerated, and it's very easy to not tolerate it. You just pick up the phone or write a letter.
Great, thank you. We have a patient newly diagnosed with PBC in August last year, taken Urzo. They've had several phone calls from the blood donation service because they used to previously donate on quite a regular basis. And they're just asking now that they've been diagnosed with PBC and they're taking Urzo, can they still donate blood? Is it safe to do so?
Yeah, so yes, it should be fine actually. Provided that the liver disease isn't very advanced. It might be that if the liver disease is advanced, if advanced cirrhosis or even hepatic decompensation, then I think probably you wouldn't want to be donating blood because your physical condition might not cope with that all that well. But if it's reasonably early stage disease or even moderate fibrosis, then blood donation should be absolutely fine. The blood donation service obviously have to err on the side of caution. So very occasionally they will require a letter from somebody saying, I've checked and it's absolutely fine for this person to donate blood. We'll keep this under review or something like that.
If it's needed. That's great. Thank you. I'm just going to ask that this isn't on your list, Doctor, but I'm just going to ask this one just now because I'm aware the patient's in the room with us here on Click Meeting. We've got increased elevated AST and ALT. PBC markers, ALB and bilirubin are good. AIH has been ruled out on a biopsy report. Symptoms that experience are dizziness since starting Urzo, also balance issues, which started about a year before Urzo and is getting worse. A VNG vestibular test was normal, having some memory and cognitive problems, sometimes struggle finding the right words. Recently started losartan, 12.5 milligrams for blood pressure, sleeping well and don't suffer from fatigue, but does have some itching. Are there any further tests or procedures that are recommended based on the symptoms and elevated enzymes?
Well, starting with the elevated enzymes, it sounds, if this person has ended up having a liver biopsy, then it sounds like the consultant in charge of the case has probably considered just about everything. Liver biopsy, generally, we would consider to be a fairly definitive test. So if that's been done, if that's excluded autoimmune hepatitis and possibly, I don't know, because we didn't get that piece of information, excluded steatotic liver disease, steatohepatitis, fatty liver, then you'd probably be okay to say that the elevated transaminases are because of the PBC itself, and to just focus all of the treatment on that. As for the symptoms, dizziness, I think, unfortunately, we would need a little bit more information about the nature of the symptoms and what is meant by dizziness. Dizziness is not usually a symptom of PBC, even in the fatigue symptom complex. On the other hand, lightheadedness and a feeling as though you're going to faint when you stand up, for example, that can be a feature of PBC in people who've got the fatigue symptom complex. And it sounds as though if this person is experiencing some memory disturbance, word finding difficulties, that sort of thing, then they could have the sort of brain fog of PBC, which is a feature of fatigue symptom complex, and that might link those symptoms together. But it's the sort of symptom that would need to be teased apart, so to speak, before deciding that it's all down to PBC or concluding that something else needs to be thought about.
Great, thank you. We have a question coming in live here as well. It's asking about if patients put on OCA, when should your first follow-up be and how often should you be seen?
Well, this will depend. I mean, there's no hard and fast rules. So it'll depend very much on the center which is prescribing the obeticholic acid. And it'll also depend on the stage of the liver disease and the severity of the disease activity when the obeticholic acid is started. It might be, if the liver disease is fairly advanced or the disease activity is quite severe at the time of starting it, or the person had experienced some itching in the past and you wanted to be sure that they didn't get itching again, you might actually get some follow-up blood tests and do a phone call a month after starting obeticholic acid. If the situation is not so extreme, then you might be happy to chat with the person after 3 months, and so on. But it really, there's no hard and fast rule. So, it'll depend very much on this clinical situation.
Thank you. We have a patient, 69 years old, diagnosed last year after 8 months of high LFTs. After taking urso, bloods have returned to normal within 3 weeks, except the ALP, which is just over at 135, and they're having their bloods done every 3 months at the moment just now. And all are normal except the ALP is staying at 142. Ultrasound normal, no symptoms, and FibroScan at 7.5. Is the ALP sticking at 142 anything to be concerned about? What does it mean?
Well, the alkaline phosphatase in PBC does give us an approximate measure of the amount of inflammation that's inside the liver. So the ALK phos of 142 would suggest that there's a little bit of inflammation, residual inflammation from the PBC. But we would generally say, currently, we would say that if somebody's alkaline phosphatase is less than 1.67 times the upper limit of normal, and that's usually a figure of around 217, we would generally say that the inflammation actually is so well controlled that the person is unlikely to have progression of scarring of the liver. So actually 142 is a pretty good measurement, and this person probably doesn't need to be too worried. Now, of course, I'm putting lots of probablys and so on in there as caveats because we don't have all of the information. But based on what has been provided, I think this person can be reassured that that their PBC is adequately controlled and that they're not going to encounter too many problems from it in the future.
That's great, thank you. We have a patient who's recently had an operation on their kidney, and for about 9 days after that, they couldn't eat or drink anything due to nausea and pain. So they couldn't tolerate taking their urso during that time. And they're a bit worried that they might have caused some damage by not taking their urso for that period of time. So I just wanted to make a sort of general question about the importance of taking urso, but also potentially if people have to stop it for a little amount of time, is that okay?
Yeah, and it is. It is. I mean, if they have to stop it for a week or two, it's not going to cause any problems at all, actually. So this particular individual does not need to worry about 9 days without ursodeoxycholic acid. It can probably be stopped for even longer than that, actually, but obviously you wouldn't want to be off it for too long because it is a medication which helps to control the PBC and to prevent scarring of the liver. But days, absolutely fine.
Great, thank you. Question asking if there's a close relationship between PBC and SIBO, small intestine bacterial overgrowth. If so, is it because of the reduced bile flow, which cannot wash away the bacteria through the digestive system effectively, so bacteria builds up? And do both conditions cause a drop or deficiency in iron, calcium, and vitamins B12 and D?
There isn't a close relationship between PBC and small intestinal bacterial overgrowth. However, there is an association between PBC and other conditions, such as systemic sclerosis, which themselves can cause small intestinal bacterial overgrowth. So it's unlikely that the PBC has caused this, but it could be that the PBC is associated with something else that has caused it. PBC doesn't, on its own, shouldn't cause malabsorption unless it is very advanced. Very advanced PBC with significant reduction in flow of bile might impact on the absorption of fat-soluble vitamins, but we really don't see that very often these days. That's something that really occurred historically. Earlier stages of PBC don't cause malabsorption, so PBC would not explain a deficiency in iron, calcium, or B12.
Great, thank you. A question about urso and asking why it says after the first 3 months to switch from 3 times a day to once daily in the evenings. Is it more effective to take a dose after each meal? We've been asked this question quite a lot. I think it can differ from patient to patient.
Yeah. So, I mean, actually, it's a very flexible drug, and it can be taken any which way you like, basically, as long as you're getting the daily dose in. It can be taken all at once. It can be taken in divided doses. It's absolutely fine. And usually the reason that people suggest divided doses or all at once has less to do with the effectiveness of the drug and more to do with the tolerability of the drug. So some people find it more tolerable if they take a smaller dose more often. Other people find it more convenient if they take a bigger dose once a day. It's really either approach is fine in terms of effectiveness.
That's great, thank you. Question about fatigue. What is the current understanding of the mechanism of fatigue in PBC?
Yeah, this is a sort of exam question, actually, which and probably the best thing to do, actually, I think, if we've not had a recent update in the bare facts, probably the way to address this actually is to provide a new summary of current
Sounds good. Yeah. Mm-hmm.
bare facts. But very, very briefly, we think of the fatigue of PBC as being either a central fatigue, which is more the sort of brain fog that people experience, or a peripheral fatigue, which is more a sensation that there's just no energy left inside your muscles. The latter, the peripheral fatigue, it has been shown that people with peripheral fatigue will flip over to what's known as anaerobic metabolism earlier than people who don't have fatigue. And that anaerobic metabolism is a particular way of handling or utilizing oxygen to produce the energy that muscles need to work, which results in a buildup of lactic acid. And a buildup of lactic acid means that those muscles sort of seize up to some extent. But why that should happen is not entirely clear. So we don't really know the mechanism there. We just know that it happens.
Mm-hmm.
And then for the central fatigue, again, we don't really know why any of these things happen, but it has been observed through various tests that that things like functional connectivity between the brain cells, central activation, which can be measured in different ways, and neurotransmission all seem to be altered. That would explain why people experience the symptoms that they experience, but we still don't really know why it should start in the first place. So I think the answer is probably that we don't really know, but there are a number of observations which would help to explain why people feel like they do.
Mm-hmm.
And hopefully those observations will also slowly but surely lead us towards treatments. But as you know, there are very few treatments available or on the horizon at this point.
Thank you. Question around second-line treatment generally only available in tertiary care and not in many general hospitals in the UK who have gastro and hepatologists, especially when they have access to blood tests and scans, etc. And the wait to get to that care seems excessive just to start a second-line treatment, when potentially you should be offered first-line treatment as soon as diagnosed. So why not second-line as well?
Well, I mean, either model potentially would be fine. I have to admit that I am a fan of the model that has been set up in England. It wasn't actually set up in Scotland, Northern Ireland, or Wales. It was adopted in England, whereby there was an MDT, a multidisciplinary team, in the regional centre, the tertiary referral centre, which would review all of the cases across the region and decide who would benefit from second-line treatment. And the reason that I'm a fan of that is because the drugs are then used in a regulated manner. The danger with completely new drugs is that we don't really know too much about them. We know what we read from a clinical trial. We know that they work, but we don't really know how they're going to work in real life, who they will work best in, what side effects they're going to cause in real life, and whether they're going to cause harm to certain populations of patients. And if you use those new drugs in a regulated manner, then there will at least be a team of people who rapidly acquire knowledge, understanding, and experience of those drugs, and can begin to use them to their best advantage. If you don't adopt that approach, if you just say that everyone can start using these drugs on day one, then what will happen is that a lot of people will feel afraid to use them. So people who should be getting the drugs won't get them. And you will have a lot of misuse of the drugs. So they'll be used when they're not really shouldn't be used, and may indeed cause some harm to patients. And there were, as you'll all know, there were some examples in the US where use of obeticholic acid was not regulated in the way that it is in the UK. That obeticholic acid was used at the wrong dose in people who had advanced liver disease, and probably sped up the deterioration of those patients' liver disease such that they needed liver transplants and some died. And that's exactly what you do not want to be happening when you introduce a new drug. Obeticholic acid is a great drug. It works very well, but it shouldn't be used in a certain group of people. And you can rely on a specialist team to know when it should and shouldn't be used. So that's my view. But alternative approaches are, can be employed. The one thing I would say in practice, though, is that when we compared use of second-line drugs in Scotland, where anybody can prescribe them, to use of second-line drugs in England, where a specialist team is needed to prescribe them, the rate of prescription was no different, in fact. And the only thing that was different was that fibrates, which are not licensed for treatment of PBC, were used more commonly in Scotland, whereas obeticholic acid, which is licensed for use in PBC, was used more commonly in England. I don't know what to take away from that, but the point is that it made no practical difference, actually, in terms of the rates of prescribing. So, so I guess, irrespective of whether you're a fan of MDTs or not, the proof of the pudding is in the eating, and there was fundamentally no difference.
Thank you. Got a question about bezafibrate now, asking if you're on bezafibrate, should you drink a lot due to potential kidney issues?
No, you should drink as much as you think you should be drinking based on your thirst. You won't be able to, if bezafibrate is going to affect your kidneys, then drinking plenty is probably not going to prevent that. Bezafibrate probably won't affect your kidneys, and therefore there's no need to get too stressed about it. The main thing actually is that it needs to be monitored. So generally, if we're starting somebody on bezafibrate, we'll ask them to have blood tests every couple of weeks for a couple of months, just to be sure that they're tolerating it, and then we'll continue to keep an eye on the kidneys every 3 months or thereabouts thereafter. That's much more important than getting stressed about now having to drink 2.5 litres a day or something. Just obey your thirst.
Great, thank you. I'm going to take a question from the live stream here. Talking to some women going through the menopause, they said they itched until they were given large doses of estrogen. Is that ever looked at in PBC patients for itch?
No, so I mean, itching can be a symptom of menopause for a variety of different reasons. So I can see that if the itch were mainly related to the menopause, then the itch might improve when the person began hormone replacement therapy. In somebody who already had PBC, then you can imagine that menopause-related itching would be that little bit worse, but would nevertheless improve once the HRT was started. So I can certainly understand why this person might have felt better once they'd started HRT. I don't think it would really be appropriate, though, as a treatment in somebody who had not gone through the menopause. So I don't think we could, for example, if you had a man with itching, I don't think that we could realistically offer estrogen. And if you had a premenopausal woman with normal menstrual cycles, with itching from PBC, then I don't think offering them hormone replacement therapy would be appropriate. I guess you could see what happened if they went onto estrogen, onto oral contraception. But generally, we find actually that when we give high doses of estrogen to people with PBC, that actually the itching gets worse. So I'm not really sure that an oral contraceptive for somebody who is premenopausal would be appropriate either. So I think the answer is no. Actually, it hasn't been looked at as a treatment, and I can't really see how we would practically use it as a treatment, except in somebody whose itching was worse post-menopause.
Yeah. We have a more general question about the itch. Patients saying that the itch is their worst symptom. It feels like insects crawling on my skin and occasionally sting-like sensations. It's especially worse at night, and I'm constantly checking for creepy crawlies in their bed. Their scalp also itches. And they're asking if you can just explain a bit about the itch associated with PBC. But the way that patients describe their itch is what we hear, isn't it, in terms of insects, creepy crawlies, that type of thing?
Yeah, I mean, on that particular part, although we call it an itch, it actually can be a variety of sensations. It can be, pain, it can be a burning, it can be this crawling sensation, it can be pins and needles, it can be many, many different things. When I read this description, I thought that was actually a very characteristic sensation of the itching that people have with PBC. The exact mechanism, I'm afraid, we don't really know. There's a lot of different theories, but we don't have an exact understanding of why the itching happens. It has got something to do with cholestasis, because when we treat the cholestasis effectively, cholestasis means the impairment of bile flow. When we treat that impairment of bile flow effectively, the itching does seem to improve. So it has got something to do with that. But there are other factors involved, because one person can have, because if you've got two people with exactly the same severity of cholestasis based on their blood tests, one can have itching and the other can be fine. So it's not just that, but that does have something to do with it. My one thought really when I read this question was that irrespective of the mechanism, which is not completely understood, this person's itching is clearly not adequately controlled, and they would probably feel a lot better if it was adequately controlled. I don't know what treatments they're taking, but I think that they should probably speak with their clinician to just discuss some investigations to make sure that other causes have been sought, and to have a look at what treatments are available, what additional treatments might be available for the itch.
I think sometimes you can underestimate the impact that severe itch can have as well on quality of life. So I would say that as well. If we can help at all with that, please give us a ring at the foundation as well. But I think it would be worth a discussion about potentially what she could try for it.
Yeah.
So we have a patient, 49 years old, detected with positive AMA2 4 years ago. They're taking 1,000 milligrams of urso a day. Levels are still not normal. Alkaline phosphatase is not lower than 200. The doctors that she sees isn't an expert of PBC, but has said to her that's okay as it is at the moment. Is that really true, or maybe I need another treatment?
Yeah, well, I mean, yes. I mean, strictly speaking, the threshold, depending on what the upper reference is, the threshold for second-line treatment is generally taken to be ALK phos 1.67 times upper limit normal, which is usually 217.
Yeah.
So if this person's ALK phos is never lower than 200, but it's about 200, then I guess strictly speaking, the local doctor is correct that they haven't met the threshold. But it might be worthwhile the local doctor referring on to the regional centre, depending on where this person is and what the local model is. Because in younger people, we would often consider second-line treatment at lower treatment thresholds. And that's not ageist, it's simply that you're anticipating that this person has got a few more years to deal with the PBC, a few more years when they can develop scarring of the liver, and therefore you might want to adopt a slightly lower threshold for second-line treatment. And that, I guess that could apply here. It's difficult in all of these instances, though, to really know without all of the details. It's difficult to know what exact advice to give. So I think probably what this person needs to do is to have another chat with his or her consultant, and really get to the bottom of whether second-line treatment is or is not, whether they'd be eligible for second-line treatment based on the local doctor's understanding. And if they're still not happy with those responses, then simply ask to be referred. We're allowed to ask for that.
Great, thank you. They also had a follow-up question after the diagnosis with PBC. They're aware that there are a lot of potential other autoimmune conditions, What are the most common other autoimmune conditions to have with PBC?
Well, the most common would be Sjogren's, secondary Sjogren's, which is the dry eyes and dry mouth. That's so common that we often consider it to be a symptom of the PBC itself. Hypothyroidism, so underactive thyroid. Raynaud's phenomenon, which again is probably part and parcel of the PBC. And then the other ones are slightly less common, but nevertheless associated, things like systemic lupus erythematosus, Sjogren's disease, rheumatoid arthritis.
Great, thank you.
Yep.
Just checking our stream there for other questions coming in. Patient diagnosed PBC, been having hospital outpatient appointments with a hepatologist at the local hospital. They're on Urzo and blood results are fine and stable. Again, it's a similar one around that the patient feels that their symptoms are being ignored. He is now referred back to my GP as he doesn't believe I need hospital follow-up. Should they be concerned?
You know, unfortunately, it's impossible to answer these questions with any degree of to be specific answer.
We appreciate that. Yeah, it has to be a more general answer. Yeah.
We don't have all the details. If the symptoms are severe, then I think GP follow-up would really not be appropriate. Simply not because GPs aren't excellent doctors, they are, but they don't see very many people with PBC. They don't see many people who've got severe symptoms from PBC, and therefore they're unlikely to be able to offer really good advice about how to deal with those symptoms. So if a person has a heavy symptom burden from their PBC, then it's probably best that they stay under a hospital which has expertise in managing those symptoms. If somebody has mild symptoms, then I guess it's a slightly different story. So if someone, for example, has mild itching, and every time you say, well, would you like to take something for the itching? And the answer is no, I don't need anything extra, but I still got some. Then I guess you could make the argument that the hospital is not actually doing anything extra for the symptom, and perhaps it would be acceptable for the GP to keep an eye on it. GP follow-up is okay under certain circumstances. If, for example, the PBC is well controlled, if the PBC hasn't remained stable in terms of the stage of disease, so it's early stage and it remains early stage, it's moderate stage and it's remained moderate stage, for example, or even if it's cirrhosis and it has remained stable, it can be okay for the GP to take over the management. If you're in a situation where the person, for example, has many other medical problems or is quite old and frail now and is struggling to get to the hospital and so on, it might be the case that actually it's better for the PBC to keep an eye, for the GP to keep an eye on the patient and to alert the hospital if there's any changes. So GP follow-up in itself is not a problem, but all of these decisions are very individualized, very contextual, and without all of the information, I'm afraid it's not really possible for me to say whether GP is appropriate in this particular instance or whether really the follow-up should be back with the hospital. And it's the usual thing. If the patient is concerned, then what the patient needs to do is I mean, by all means, post the question here, but really what they need to do is to have a chat with the GP and say, well, look, I'm uncomfortable about this arrangement. Should we think again?
Great, thank you. And I know sometimes that can be a difficult conversation for patients to have with their clinicians, but we're here to support on that as well. And we do have some really good documentation about preparing for your appointment and questions to ask about your PBC. So if anyone needs anything like that, please just reach out to us at the Foundation as well. So we have a question about managing arthritis pain with PBC. Patient can't tolerate anti-inflammatories and paracetamol is hardly touching the pain. Are there any supplements that are safe and might help?
The issue with supplements is that people love supplements for some reason, but don't like drugs. Yet it's the drugs which have been studied and not the supplements. So, and I'm afraid my trade is in the drugs. So I can't really offer any supplements, I'm afraid. I suppose what I would say is that if it depends again on what sort of arthritis are we talking about. So if this is osteoarthritis, if it's wear and tear arthritis, then sadly it is usually painkillers which are the mainstay of treatment. Of course, joint replacements and so on can be very helpful, but generally it's painkillers. If a person can't tolerate anti-inflammatories and paracetamol isn't doing the job, then we would often step up to the opioid type medications, things like codeine, metazanol, tramadol, and so on. But these are all discussions that are worth having with the GP to see whether it's worth moving on to those additional medications. The other thing to say, of course, is that physiotherapy can be very helpful. The pain of arthritis. If this is an inflammatory arthritis, rheumatoid arthritis, for example, then it might be that is not perfectly controlled, and this person might need to speak with their rheumatologist about it.
Great. I would also mention that on one of our sessions, Professor Neuberger spoke about pain relief and medication and the different types of pain relief. As you'd mentioned, they're the different types, ones in quite detail, and that video's up on our YouTube channel as well, if anyone's got any. There's quite detailed information on that as well. We're coming towards the end of the session now, but we have 2 questions in the room here in ClickMeeting that I wanted to get to before we finish. So there was a question around, and I don't think I've had this one before, a question around tomatoes and PBC. Someone is having a craving for tomatoes, but has been told that they aren't good for PBC. Any information on that?
Yeah, I must admit, I'm not aware that. I would have to check that separately, actually, and get back to you. Perhaps if I write to you, Mo, then you can let this individual know. But I'm not aware that tomatoes are bad for PBC. But it's difficult to know without checking, because that's quite a specific question.
Very specific, yeah. And then the last one in the chat there, asking about an ANA GP 1210 positive test results with normal range ALP and GTT, but have a raised ALT for a few years. Does that confirm you have PBC?
Well, yes and no. We would generally say that you need the combination of an elevated alkaline phosphatase with a PBC autoantibody to make the diagnosis. Early stage disease can be characterized by elevated ALT rather than ALK phos, so it could be that this person has early stage PBC. But strictly speaking, it's the combination of alkaline phosphatase and autoantibodies which clinches the diagnosis. So I think this person might need to chat with their consultant just to make sure that there aren't other possible conditions being missed. So, for example, autoimmune hepatitis, fatty liver.
Great, thank you. And that's us just drawn to an end of the session now. Thank you so much for joining us, Dr. Mells. It's been lovely having you today. If we didn't get to your question, we will hold it over for our next session next week. And I'll also pick up any questions that have came in the live that we haven't had time to ask either, and I'll add them onto our list for next week. But thank you so much for your time. I have one question that I have to ask you before I'm allowed to let you go. Are you coming to the summit in April?
Yeah. I'll come to one of the days. I don't know, the day I'm meant to be there, I will be there.
Brilliant, thank you. You should have received the registration forms have gone out today as well, so you should receive that into your inbox today as well. Thank you so much for your time. We really appreciate it.
Thank you. Thanks for the session. Okay.
Take care. See you soon. Bye.